Epidemiology is the study of disease in populations. We're going to study the frequency and distribution of disease and other health-related factors identified in populations when we're talking about the study of epidemiology. It does involve quite a few things. It's not as simple as, okay, this is all we're going to use, this is it. Because of the nature of the diseases that we're studying and how they affect the body, you've got different disciplines going into this: microbiology, anatomy, physiology, immunology, medicine, psychology, sociology, ecology, and statistics. When it comes to marking the progression of a disease or studying how a population is affected, you have to also think about things that are beyond just this is what the body's doing, because different cultures, different beliefs have effects on your health. What you eat can have an effect on your health, but what you eat can also be influenced by the culture that you're in. And these types of things also need to play a role in studying the epidemiology behind the progression of a disease. It considers all forms of disease. We're not just talking about COVID-19. We could be talking about the progression of heart disease, of cancer, of drug addiction, of mental illness. It's not necessarily just, and the swine flu went through the population like. Instead, it's kind of all inclusive. Things like heart disease do affect certain populations more than others because genetically we are predisposed to those things. Drug addiction, if you think about socioeconomics and things like that, does affect certain subsets of the population more than others. Specifically, it affects the poor. Now, why might that be? Well, if we're talking about the escapism of using drugs, that's more of a psychology thing, maybe even a sociology thing, because we're talking about society as a whole and not just one person for psychology. So let's talk Florence Nightingale. Florence Nightingale was actually a nurse who in the 1850s was assigned in Turkey to a war zone for the Crimean War. She is responsible for laying the foundations of our concept of modern epidemiology. Before the discovery of germ theory, the idea that there were things that were living in our environment that we couldn't see that would make us ill, before we even realized that, before we had the foundations for that, she understood that filth, dirtiness, was contributing to the formation of disease in her patients. So at this particular hospital that she was working at, she instituted methods that at the time were fairly revolutionary. Even though today we would go, well, duh, at the time, this was not something that was widely done. So she wanted separate linens and towels for each patient. She wanted clean floors. Now remember, this is a war zone where bad things are, happening and soldiers are being brought in, with grievous wounds, and she wanted clean floors. Again, this was not something that at the time people were going, oh yes, we need to clean the floors. They didn't care, but she was adamant, the floors have to be clean. Something else, she wanted the sewage lines unclogged. She didn't want them backing up. And again, in today's society, we would go, well, duh. But at the time, you're in the middle of a war, you don't have time to worry about that. But she knew something was coming from that. There was a result from that. She kept really meticulous notes and demonstrated that more men during this time frame died from disease than from their wounds. And again, this is a woman in the 1850s. Nobody listened to women in the 1800s. They didn't know anything, right? But she had data. She had hard data that they couldn't dispute. They kind of started listening because it wasn't just her as most men in that time would say, being hysterical. It was, here's the data, here's hard data, here's facts to back up what I'm saying. So epidemiologists in general will identify causative agents and kind of using adaptations of Koch's postulates, because remember, we're not just talking about a disease like COVID, now we're talking about things like heart disease and drug addiction. They track behaviors such as exercise and smoking. They collect clues on the causative agent, the pathology, the sources, and the modes of transmission. They track the numbers and distribution of cases of a disease in a community, and outcomes of these studies basically help public health departments develop prevention and treatment programs and to develop a basis for these predictions. All of this data that we're collecting helps us here. At least it's supposed to. That's the goal. The goal is, if we can understand all of these things, we can kind of come up with a plan. So how is the health-related outcome distributed in terms of people, place, and time? This is descriptive epidemiology. What hypothesis might explain why some people have the outcome and others don't? Like I said, if we're talking about drug addiction, you basically see that more in the you basically see that more in poorer communities than in richer communities. Why? What is your hypothesis on that? Is there an association between the exposure and the outcome? This is analytical epidemiology. Is the association between the exposure and the outcome a causal one? This is causal judgment. With the flu, exposure has a lot to do with who actually catches the flu. But if we're talking about drug addiction, is it the same? Is it because as a child I was exposed to people doing drugs, I think it's okay to do drugs? That's why I said it's not necessarily just, immunologists doing this. You actually have to take in the psychology and the sociology and social situations, and all of that is kind of under this blanket. What should be done to prevent or control the outcome? Individual and societal decision making. Is this something that we can control? With COVID, wear masks, wash your hands, those types of things. Or is it something more complex like drug addiction? Did the prevention or control strategy work? This is evaluation. Did our ideas of how to prevent this from happening actually work, or did they not? Those are the kinds of things that epidemiologists are doing. They're looking at all of these different angles. They're getting data from all of these different angles and trying to come up with a way to prevent these things from happening. And then they evaluate. Did it actually successfully work? Did it kind of work? Did it not work at all? Tracking disease in a population, reportable or notifiable diseases. There are certain diseases that must be reported to the authorities. Other diseases are reported on a voluntary basis. There is a network of agencies and individuals at local, at district, at state, at national, and international levels that keeps track of infectious diseases. Just to give you an idea of what diseases are kept track of, in the United States, this and this are the reportable diseases that we keep track of. Again, this is something that we want to keep track of, because if it's something that's spreadable, if it's something that affects a large percentage of the population, these are all things that we want to know so that we can try to prevent it, or we can see if we're going to have another pandemic on our hands. Statistics. Statistics is the math behind all of the data. And I know people are math, bleh, but again, hard data is really, really hard to argue with. If you have hard numbers, real numbers that track the progression of a disease, that track how many people get it, they can't argue with facts. The prevalence. is the total number of existing cases within a given population. It's a snapshot. What are the numbers today at 12 p.m.? What are the numbers a month ago at 12 p.m.? The total number of cases in a population divided by the number of people in a population times 100. This is literally just a percentage. How much of the pie has the disease? If I were to give you an example, that would be the prevalence of smoking among adults in the United States is about 17%. Incidence is different than prevalence. This is the number of new cases over a certain time period. The number of new cases in a designated time period, again divided by the number of susceptible people. This is usually reported per 100,000. It's just kind of a blanket way to represent the data, a way that makes sense to a lot of people. For example, if we're talking about Lyme disease, in 2014, 8.6 people per 100,000 ended up with Lyme disease. So 8.6 people per 100,000 was the incidence. That's how often we saw that. Continuing with statistics. Statistics of concern to the epidemiologist are rates of the disease with regard to sex. Does it affect men more than women or women more than men? The race, is it affecting Hispanics or Black people or white people? And geographic region. Remember what I said about we have huge and multiple areas that we're looking at. Even geographic regions can have very vastly different spread of a disease than other places. If we're talking about Tokyo in Japan, that is one of the most population compacted places in the world. You have people living in pod rooms, you have people living in apartments, stacked up. Apartments that are smaller than my bathroom at my house, which means that you have people in very, very close contact with each other. That situation influences how a disease is spread compared to, I'll even say Alice, Texas, or Kingsville, Texas, where people have their own houses. They're fairly big houses compared to pod rooms in Japan, that they have space between people. Once I leave the school, I'm at my house by myself with my 2 cats. I don't run into other people. That influences my contact with other people. If I lived in a pod apartment building in Japan, they have community bathrooms, they have community showers, they have all of these community spaces because your little pod room doesn't have a kitchen. Push comes to shove, you're gonna run into other people once you're home for the night. So all of these things influence how those statistics are presented. The mortality rate measures the total number of deaths in a population due to a disease. The overall death rate from infectious diseases has dropped. Although the number of persons afflicted with the infectious rates, the morbidity rate has remained high. Morbidity is people getting that disease. People still get diseases. We've just come up with better ways to treat it so it isn't as deadly. So 2000 to 2014, this is the incidence of acute hepatitis C by age group within the United States. Per 100,000, how many people have gotten it? And here's the year. So year, time passing, how many people had it? Hepatitis C was seen in the most prevalence in 40 to 49-year-olds, our green line, in the year 2000, followed by our turquoise line, which is 30 to 39, followed by our kind of orange-yellow line, which is 50 to 59. But you can see as time went on, the incidence went down quite a bit. You can see around 2009 that there are 2 subsets of my population, age groups, that number starts going up. When you look at my 20 to 29-year-olds who had lower incidence in 2000, by the time that we get to 2014, their numbers have gone up. The incidence of the hepatitis C in the population has gone up. My 30 to 39, again, that pretty much went right back to where it was in the year 2000. Now you have to remember something. Because of the passage of years, these populations are different people. When you look at this graphic representation, it's color-coded and pattern-coded to indicate Zika virus prevalence in the United States in 2017. The darker the pink, the more cases were reported. These disease cases include cases in travelers returning from affected areas, cases acquired through presumed local mosquito-borne transmission, and cases acquired through other routes. So anybody, it doesn't matter how you got it, anybody who presented with Zika is counted in the numbers. Cross-hatching, the stripes that you see here at Puerto Rico, this signifies local mosquito-borne transmission in 2017. If you look at the entire map, this is the only one that really has cross-hatching. But if you look at the different states in the mainland of the United States, there are several that didn't have anything. Up here in New York State, it's the most prevalent as far as the United States. It's the darkest pink with 50 to 100 cases. But if you think of New York State, that's where New York City is, and you've got a really dense population. Remember what I said about epidemiology. We don't just look at one thing, we look at a lot of different things. So why represent it like this? Having a geographical representation of where a disease is most prevalent, remember I said geographical information may play a role. This kind of puts it in picture format, the geographical representation of where the disease is most prevalent, where it isn't. So it may give even more information for somebody to analyze. So terminology. An index case. It's not necessarily the first case that ever happened, but it is the first case that brought the epidemic to the attention of officials. So an index case is the person that we see as, oh, they're the first ones that really spread the disease. Endemic, sporadic, epidemic, and pandemic. Endemic is an infectious disease that exhibits a relatively steady frequency over a long period of time, but usually in a particular geographic location. It doesn't really spread. So endemic, you may see little spots of disease popping up, but it doesn't spread out from that location. It kind of stays right where it's at. Sporadic, these are occasional cases that are reported, but they're normally at irregular intervals and at random places. An epidemic is when the statistics indicate the prevalence of an endemic or sporadic disease is increasing beyond what is expected of a population. So instead of it staying in that one spot, now it starts to spread in the area. In a pandemic, this is when our epidemic starts spreading around continents. One of the reasons the Black Plague didn't spread around the world, people didn't travel like they do nowadays. You can hop on a plane and be in Australia in 48 hours. And if you kind of started feeling weird before you got on the plane, but you got on the plane anyway, if it's an airborne virus, there's probably a good chance that you spread it to people on the plane. Once you get to Australia, those people are going to go their separate ways. Maybe there's a guy who's on a business trip, because we're in Texas. Let's say I left from Texas. Maybe there's a guy who's on a business trip in Australia and you've given it to him, but in Australia, he's okay. But then he flies home and he's actually from Nevada. And he gives it to his family. And his kids go to school and give it to the other kids at school. And then those kids go home and give it to their parents, who go to work and give it to people over there. And let's say there's a businessman who's on a trip from Japan, who's also, part of a meeting that they're in. And then he goes home feeling fine, but then he gets sick when he's at home and he spreads it to his family. This is how things globally get around. In modern day society, we don't necessarily stay in one place. Yes, I know there's still a lot of people who are born in one town and stay in the same town their whole life. But I'll be honest, I was born in Kingsville, that is true, but I have lived and traveled to different places. I've gone to Australia and visited for 32 days. I've gone to Cleveland, Ohio and lived for 3 years. I've lived in Galveston. I've lived in Lubbock. I've lived in other places. So just because I came to Kingsville to visit my family didn't mean that I stayed here. And if I picked up an illness here and I traveled to wherever, I could take it with me. The ability that we now have, the ease with which we can travel, which really didn't exist in the past, helps us to spread diseases like nothing else. So a common source epidemic, we're going to kind of subcategorize. A common source epidemic results from a common exposure to a single source of infection over a period of time. A few years back, Bluebell ice cream pulled all of its ice cream from the shelves because it was found that one of the machines had listeria in it. It would have been a common source, Bluebell, but think about how far and wide they actually sell their ice cream. So this one machine could have spread that quite a ways away from where the factory for where Bluebell is. So it would be a common source epidemic. All of the people who got listeria got it from the Bluebell factory. Point source is a bit different in the fact that the infectious agent came from one single source and all of its victims were infected at once. So there's a church picnic and somebody brings potato salad and the potato salad is bad. Everybody who ate the potato salad at the church picnic is going to get food poisoning. But it doesn't really spread past that. Nobody else got food poisoning because nobody else was at the church picnic. That's point source. It's one place and it stayed within that population because it's only the one place. A propagated epidemic. Now, to propagate means to reproduce, to make more. So in a propagated epidemic, you've got an infectious agent that is communicable. It can spread from person to person. Normally, things like this are going to be more sustained, so longer periods of time, because they are being passed from person to person. But with most propagated epidemics, you kind of have an infectious agent that eventually peaks, kind of comes to a high number, and then starts coming down. The number of infected people starts decreasing. One of the reasons that the decrease happens could be due to control measures. If this has been going on for a few months and we know that it exists, most communities will take control measures. Okay, you need to start washing your hands more often. Okay, if you start feeling sick, please don't come to school. All of those types of things, especially if it's something really bad. Hello, COVID-19. But the control measures help that kind of come down. However, at the end of this, where it kind of flattens out here, at that point, usually it is more about features of the virus and not necessarily control measures. The virus is kind of petering out. In a pandemic, you've got disease that is widespread. It's across the globe. COVID-19 is a really good example of this. So statistics-wise, remember I said numbers are important. When a pandemic is ongoing, the data actually will change fairly quickly daily. The table reflects the number of reported cases and deaths in the United States, and throughout the world on August 20th of 2021. So if you look at the number of cases, in the United States, we had 37 million reported. In the world, it was 209 million, almost 210 million. The number of deaths, again, on August 20th, 2021, 623,244 just in the United States. Globally, 4,400,284. Hard data numbers. Here's a week's worth of Zika data represented as a color-coded United States map, along with its territories. Having a map like this that gives you numbers based on location also helps with that geographic mapping. One of the things that with the current pandemic I've heard a lot is that COVID is just like the flu. It isn't. The mortality rates, how many people died from different countries. The number of people who died from the flu compared to COVID. Those numbers are very, very different. The population mortality percentage is very different. This is 1.6%. This is almost 9%. Now I realize that you're probably going, okay, but it's still just in the single digits. 9% of the population of the United States is a lot of people. And you know this, if you've watched the news in the last 2.5 years, the number of people that have died are enormous. You can compare all of this data for all of the countries, and there are very few that don't have higher mortality rates from COVID than the flu. There are some exceptions, but not many. And when you look at the difference between COVID and the flu, there is a very large difference. So 2 other concepts, communicable versus deadly. So when we talk about communicability, we're talking about how easy it is to spread. When we're looking at data, this is represented by R sub 0. The reproduction rate is what we call it. How many susceptible people will contract the disease from one infected person? So for example, with measles, the R sub 0 is 15, meaning one person with measles has the capacity to spread it to 15 people. The more communicable it is, the easier it is to spread. The less, again, the less it is, the less the ease it spreads with. As far as deadliness goes, we measure something called the case fatality rate. Basically, the number of people who die within a specified time period versus the number of people, or over the number of people infected. Now, something you have to understand, we're talking about people without treatment. This isn't somebody who goes into a hospital and gets treated while fighting a disease. This is people who don't have any treatment. A really deadly disease that is 100% deadly if you don't seek treatment is rabies. Rabies, if you get rabies, there is a window for them to treat you. And if you don't get treated within the window, they can try and make you comfortable and they can watch you die because it has a 100% mortality rate. These measures of infectious disease are approximate and can vary based on, again, geographic location, but the general idea of R sub 0 and my CFR can actually guide a lot of healthcare decisions and policies. Diseases with an extremely high communicability, or R sub O, for example, are ones for which vaccination is most needed. COVID was one of these diseases. It was spreading, and it was spreading really fast. And it was killing people. So not only was it highly communicable, but it was very deadly. And they pushed to get to a vaccine. I'm going to talk about the COVID vaccine in chapter 13, but understand that I know everybody goes, well, it was a year and that was just too fast. RNA vaccination has been in development for over 25 years. It wasn't that fast. They just needed to wrap up the 25 years worth of stuff that they've been doing. So looking at these graphic representations, on the left, I have the deadliness of a disease, and on the right, I have the communicability. Deadliness, I've got rabies, HIV. Below that, I've got TB, Ebola, plague. Below that, I have syphilis, and then I've got rhinovirus, malaria, dengue fever, basically, seasonal flu, rubella, smallpox, pertussis, measles, rotavirus, hepatitis B. So these are not necessarily deadly. 1 to 24% of people, or 0 to 24% of people will die. So not as deadly as other things. But when you look at the communicability, how easy it is to get, how easy it is to spread, those things that were at the bottom over here are actually at the top here. Measles, malaria, mumps, rotavirus, pertussis. These are extremely communicable. They are easy to spread, whereas the rabies and HIV are actually at the base here. You can't get HIV from sitting on a toilet after somebody sits on a toilet. You can't get rabies from, I don't know, handling a Kleenex. It's not that easy. These are things that you kind of have to weigh if you're an epidemiologist.